Hello, everybody who's joined in. Good to see everyone. I'm Geer, and I'm putting this together with Dr. Kate Lampensacker. And today's roundtable, we're going to be talking about a hot topic, teaching strategies in a high volume environment. We have four educators here to talk on this topic. Dr. Tabby Kennedy from University of Wisconsin, Dr. Gary Danton from University of Miami, Dr. Pallav Shah from St. Luke's University Health Network in Pennsylvania, and I'm Geer from Wake Forest. Please put any questions or comments in the chat function. That's what we're going to start with. And without further ado, I'm going to turn it over to Dr. Kennedy to start us off.
All right. Good afternoon, everybody. Really happy to be here and speaking with you all today about this important topic that I think affects a lot of us in our academic practices. So I'm going to start off the discussion here talking about teaching strategies in a high volume environment. So I have a couple of different roles in the University of Wisconsin. I am the section chief for neuroradiology at UW, and I used to be the former fellowship director, and we do a lot of teaching of residents and medical students. And so I think from that perspective, it's helpful to kind of get a sense of, what are the opportunities that we can use in terms of scheduling and understanding all of the varying pressures that really affect us. So, of course, the one of the most important things that we have to think about when we are teaching and doing our daily work is the patients are really at the center of everything that we are doing, and so that's really important to keep that in mind. But of course, we have balancing pressures. We've got ever increasing volumes, lists that we have to make sure that we're getting through to do our patient care. We also, of course, have to balance our learners because we have an important duty to them to teach the next generation. And then we have time constraints. We all want to leave on time, and then we have to balance our own wellness. And so, if we aren't managing our faculty, then none of these other things can actually be achieved. So I think about things from the faculty perspective. And as the section chief, I really want to think about, are there ways that we can do flexible scheduling? So to think about creating teaching shifts and then maybe non-teaching shifts. The teaching shifts can allow us that time and flexibility so that those folks that are in the reading rooms, they have the time to be able to teach the trainees. And then non-teaching shifts allow for maybe a little bit more flexible work hours. So I'm kind of meeting the needs of the faculty. And then those folks may be able to drive the list and to get through those cases a little bit more expeditiously, where the teaching shifts were allowing for that time for the faculty to be actually teaching. So thinking about that from a scheduling perspective, working with your department leadership, your section chiefs to think, can we think about doing things differently? Another potential is to try to match the types of cases with learner level. So having the learners really focusing on specific types of cases. So if you have first year residents, maybe having them really focus on the ED cases. So that's what we do in our neuro reading room, where the first year residents are really responsible for taking those head and total spine exams from the emergency department. And then that really helps them focus on what they should be learning about. The second year residents may be focusing on the inpatient exams, and the fellows really should be thinking about those cases that are going to take a little bit more time and effort, putting the history together, thinking about tumor follow-ups, outpatient exams, etc. And by doing that, you're right sizing what the resident should be learning, and then what types of things that they're actually interpreting. That also really helps for facilitated staff outs so that if a first year resident is going to take, some really advanced tumor follow-up, it's going to take them a lot more time to get through that case. And so by kind of matching or right sizing responsibilities and learner levels, I think will allow for more expeditious review of clinical cases. I think it's important for faculty and trainees to be aware of the list. So having some list anxiety is good, not always being driven by the list, but knowing when it is possible to titrate up and down is really important. So having faculty who are aware of the list so that you're not going to spend 2 hours reviewing, a brain tumor follow-up where the whole, somebody else in the room might be kind of doing all of the staff outs. And so having everybody kind of be aware of that ends up being really, really important. So being able to titrate up that teaching up and down, responding to the list will be helpful. When it's busy, it doesn't mean that teaching goes away. It just means maybe that you pull out one important teaching point at the end of every staff out, or only focusing on, those staffing out those cases that really need critical side-by-side interpretation. So that really kind of brings us to that next point of when do you do staff outs? Do you do side-by-side staff outs in your daily practice on every single case? And so consider when side-by-side staff outs are the most needed. And maybe you could consider, do you need to do that based on the trainee level? So for the first years, I really want to spend more time with them because the focus is on making sure that they have that foundational knowledge and potentially giving a little bit more leeway for the fellows and maybe the third or fourth year residents. They can potentially operate more in an independent graduated kind of situation rather than the first years. So normal exams, for example, you may not necessarily need to sit down with the resident side by side and say, yep, that looks normal. And then potentially pulling and reserving those cases with high teaching value for the trainees and the formal staff out. So if I'm opening up a case, for example, and I see, oh, this one has a classic finding, I might not read that on my own. I'll say, hey, this one is a really good case for X resident. Why don't you do this one? And then I'll take maybe the normal sinus exam or, kind of just keeping things kind of moving on the side and having the trainee really focus on the cases that they're going to learn the most from. And then, potentially thinking about how do you incorporate case conferences in your daily work. And so thinking about, if everybody's reading actively on the list, we still want to make sure that we're pulling the important teaching points at the end of the day or maybe at the end of the morning. So consider doing a daily end of day huddle where everybody's sharing, the top 3 cases. So, or collating all of those cases at the end of the week so that you're doing a weekly case conference. I think that can allow for the high teaching point cases to be shared and that we're kind of all learning from each other. That kind of hits on a couple of different points. The residents and the fellows and the faculty have the opportunity to share those cases, and so they're working on their kind of teaching presentation, but then also everybody gets to see the great cases. And so the one challenge, of course, is that if you have a high teaching environment, you want to make sure that you're still protecting that time so that the case conferences actually can happen. And so that's what we suffer from is that, identifying when is it best to do those teaching conferences. And you want to make sure that maybe there's somebody assigned to cover the list as the case conference can happen. So that those don't get canceled. And so thinking about when's the best time of the day to do those. So maybe it's in the morning, or it's potentially at the midday or at the end of the day so that we can make sure that we're all learning from each other. And then some people may not actually all be in the same room together. And so is there another potential place to share those cases? Is it through a platform like Teams or through Zoom where people can just, kind of message each other and say, hey, there's this great case, take a look at this. And that's another potential way for people to share interesting and great cases with each other. So that's kind of a quick summary of the kind of practical things that one can do and incorporate in their daily work. So thinking about, how do we tackle a high list, increasing case volumes, thinking about right sizing, matching the type of case with the learner. Consider doing side-by-side staff outs for when it's going to be most valuable for the learner and for the types of cases. And then consider incorporating your conferences, either as a daily huddle or maybe through a Zoom call with each other, sharing the cases at the end of the day or at the end of the week. And then ultimately, it's all about patient care. And then we're wanting to make sure that we're maintaining a high level of education for our trainees. And that's what I have for you today. I'll stop sharing and then we can move on to the next speaker.
Great. Thanks so much, Dr. Kenny. Again, if you have questions or comments, just throw them in the chat, and we'll try to answer as we go.
Great, thanks. So can you hear me okay? We're good? All right. I'm Gary Danton. I'm the Vice Chair of Education at University of Miami-Jackson Memorial Hospital. I am a former program director, very happy former program director. I was PD for 14 years. I'm now an associate program director, so still very involved. And, I'm going to go over some of my thoughts and experiences. We obviously have a very high environment at Jackson Memorial Hospital, huge trauma center, 1,500 bed hospital, and then an additional 500 beds or so from the U Health system. I'm going to start with kind of a resident focus, and then I'm going to move into an attending focus. So volume is good. High volume is good, and we have to sell it to our residents so they understand that this is important. They need to learn how to read high volume. So being in a high volume environment isn't a bad thing. And we start selling that from interviews. Interviews, we're talking about being a high volume center and also warning them of the pressures of being a high volume center. And then on day one, they're welcome into residency. We're talking about the benefits and dealing with high volumes so that they believe that this is something important for them. But we have to remember that efficiency and volume is just one component of learning. So we also reassure our residents we're not dismissing people, right, because they're having, they're not reading a high volume, right? That's not what this is about. We all have faculty colleagues, right, who are not good at handling high volumes, but they're phenomenal radiologists. They may be the ones that we take our studies to read for our family members because they're amazing radiologists, but they're not hitting the top of the RVU list. So it's okay to not be the fastest person in the room. It's okay. We have to tell them this is something that they learn over time, they can work on. Some of the residents may succeed in efficiency, some may not. And we try to be straightforward with them about that and counsel them on that when they're going out and looking for jobs. Set caseload expectations. And it's good to have kind of graduated caseload expectations for your residents. How much might they read at different levels? But you have to be careful doing this because if you give them like 50 cases and then you're done, then your fast people will hit 50 cases by by noon, and then they want to be out the door, right? So we kind of explain this like an average caseload should be this number. So they know that they're not done once they hit that certain number. We also, in the busy environment, we want to set learning expectations for our residents. I have some residents that their expectation was every case was going to be a lecture. Like if they wanted a 10-minute lecture on every CT scan, no one's got time for that, right? They have to understand that, okay, you can, ask one or two questions that are pertinent to a case, right? So we had to counsel some of them on what to do. If you have a question, ask this question. If there's other questions, write them down. You have to go over them another time or study for them. And then I'll talk in a minute about how faculty can help guide them. But expectations for what they should read and then expectations for what the learning environment is going to be during those readouts. As an educator, it's up to us to assess what is enough, what is the right amount of cases for residents to be responsible for, and also what is too much. And you really need to keep your pulse on all of the divisions and figure out, where is the volume and the expectations on the residents exceeding the benefits of the learning environment. And then I'll talk about how I dealt with some of these issues. Um, a a good way to deal with them, but also a challenging way, is deciding when to add attendings who might read on their own and when to add and modify the size of your fellowships. This is a strategy that I used a lot. The volumes just became too much for faculty, too much for our residents. People were very stressed out. It was not good. So we increased and created fellowships in areas. Fellowships are great because at that level, they should be more independent. So it's not taking up much more faculty time, but it's pulling cases away from your residents and getting residents able to spend more time focusing on a healthy and appropriate number of cases. And then you may have to increase or decrease your fellowships because you also don't want the fellows to take so much that your residents lose experience. Of course, adding attendings is difficult for us as educators. It's up to chairs and departments, but sometimes we have to be the ones advocating for additional faculty based on the teaching needs. And then reassess. Every year, every couple of years, you need to reassess. If you're constantly getting flagged on your ACGME survey because the service outweighs education, you have to look into those areas and drill down to where those comments may be coming from. All right, and now I'm kind of shifting to the focus on the attendings. And I'm going to say that there's not going to be a single solution for for multiple institutions. There's probably not going to be a single solution amongst all your divisions. And even within divisions, you're not going to find a single solution that works necessarily for all faculty. So starting with the chairman, I think is important, and the institution, and assessing what is the policy on productivity for your faculty. Because if the policy of the department and the chair are hammering people on RVUs and efficiency, turnaround times, and that is what's tagged to their bonus, right? Their bonus or their salaries, then that it's going to be hard to get your faculty in a high volume environment to focus on your teaching. So I think these are important discussions to have. We're very fortunate at our chairman. Of course, we all have productivity requirements, and turnaround time is important, but they're very reasonable, right? And their impact on people's salaries is not that high. And so it's very helpful for people who know that they can spend more time teaching without this, penalty that they're going to be called in because, their RVUs were low on a particular day. So something to think about. Now, and then when you look at your divisions and you're trying to figure out all the strategies, and I love the strategies that Tabby showed, and I think you're probably going to hear about similar strategies amongst the speakers. You're gonna you have attendings who are going to teach no matter what, right? No matter what the volume, and then you've got your attendings who won't teach no matter what, right? They're just not interested in teaching. And then you have those who want to teach, but they're really stressed out about the volume, and they're just kind of, if they're too busy, they're not going to teach. And then you have attendings who work independently of residents, and those who are solely dependent on residents, right? So within your division, you got all these people, and converting one to another, it's just very difficult, right? You're not going to change attendings, not easily. Maybe a very junior attending you can coach from one into the other, but your senior level attendings, forget, very hard. So with that, when you plan, shifts, as Tabby said, where you might have your people who really love teaching on more teaching shifts, and the people who are more independent and are not so into teaching on separate shifts. And then you can rotate that around so you have people covering high volume areas who are more independent, and people covering or reading lower volume with junior level residents on other shifts. And those shifts, of course, can be at the same time, but that will take the weight off of that attending who's trying to teach the more junior residents. Also, 1 to 2 key points each case. So I like, and if you're reading, 200 chest x-rays, it may not be a teaching point on every chest x-ray, but you're reading a big case or every few cases, you have a good teaching point. You tell the faculty, please give one teaching point and make sure the resident knows you're giving a teaching point. Like, I want to point this out. This is a little bit part of selling what you're doing, right? You got to tell residents when you're teaching, you got to tell them when you're giving feedback. We used to hold up little cards that said feedback because the residents were like, I'm not getting any feedback. And we're like, we're always giving you feedback. So we'd hold a little card, feedback, and here's your feedback. So tell them, oh, I want to teach you this, right? And now I'm being taught. And your residents are going to be happier and they're going to appreciate it. But sometimes it's important, 1 to 2 for points on each case or after a series of cases, especially when it's busy. The ACGME emphasizes progressive level of responsibility and autonomy. And this is, I think, important, and you can use this to your advantage in these high volume environments. So when you give residents autonomy and you tell them, you're doing well, you're doing great, you can now read these cases on your own and send them to me in preliminary status. They're like, wow, I'm doing great, right? Where if you say, I'm not going to read you out on these cases, right? Just prelim them. Now they're like, man, I'm missing out on my teaching opportunity, right? Autonomy is good. It's good for them. It's good for their learning. It's good for their confidence. Give them autonomy at the higher levels. And even a junior resident, maybe they're starting off on ultrasound, and you're not going to have them prelim or give them autonomy on body ultrasounds, but they start reading DVT ultrasounds, and they're like, okay, well, they can handle a DVT. Hey, great job. You're ready to read DVT ultrasounds. Send them in prelim, and I'll send you any feedback. They'll be happy, and you can get other work done at the same time, right? So you're selling it, you're teaching because you're giving feedback, and you're boosting your residents' confidence. And I highlighted feedback there because I want to emphasize that if you move to a system where you're giving this progressive level of responsibility, you're giving them some autonomy, they're sending cases to you in prelim, you have to make sure your faculty send them feedback. It doesn't matter if it's verbal, if you're using a mail system in PACS to do it, but they got to get some kind of feedback, or they're going to be really disappointed in the experience. Even if it's 1 word or 2 words, good job, right? Great reports, send it to them. And then great reports, but you missed this, and this, right? So all together. And that will boost their confidence, make them happier, and allows people to get work done while still providing a good teaching experience. All right, and I look forward to questions.
Wait, I'm gonna pull mine up. All right, can you all see my slides okay?
Yep.
All right, great. And again, everybody, just be putting things into the chat. There's also a Q&A. Gary, I think someone had a question for you during that. So again, I'm Carol Geer. I'm the Diagnostic Radiology Residency Program Director at Wake Forest, and I'm partnering with one of my education colleagues, Dr. Pallav Shah at St. Luke's Health Network in Pennsylvania. He's also the program director there. And we're going to shift a little bit our focus. again, this is a math problem. It's a national math problem. In a lot of our places, there are too many studies and not enough radiologists. And we know that it is impacting education negatively in some places. Chief resident surveys have said such, and chairs are under a lot of pressure these days to really run the business of radiology efficiently while supporting faculty development, research, education. There's going to be no magic bullet to fix this math problem. And so, what are our options, for the math problem? One is we can just, if we have too many studies, not enough radiologists, and again, this is if it's not a problem at your place, it's gonna be a problem because it is everywhere, where all of a sudden your health system acquires another hospital and magically the studies are coming to your group. One option is we just delay the care for the patients. The patients just wait. I'm also a neuroradiologist, not a great idea. So I think most of us morally don't feel good about that. So are there ways that we can increase our time available to read imaging studies during sort of, quote, regular work hours? Working longer hours and doing more faculty moonlighting is not going to be a sustainable option. And then are there ways we can maybe improve efficiency of radiologists? I think Tabby and Geer have talked some about that in the reading room, but it does have its limits, and AI may be able to help us some there. There are education requirements for a training program. I mean, one, Geer and Tabby talked a lot about what I would say clinical teaching at elbow, if you will. This is having residents look at cases, and in some manner you review the cases, and depending on level of learner, that may be longer or shorter, but, going over search patterns of pathology and, report quality and giving feedback. And that, when we're clinically teaching at elbow, we are reading studies. That's good. We're tackling the math problem of a lot of studies, but there's a lot of things we need to do in education that are outside of the reading room and that take time. We got to deliver a didactic conference curriculum, provide quality improvement education and projects for the residents, scholarly activity opportunities, non-interpretive skill education for milestone progression. All of these things are not in the reading room, and when we're not in the reading room, we're not reading cases. And then there's more. We've got to prepare trainees for the board exam. Some of that happens in the reading room. We've got to write letters of recommendation. Lots of faculty have to do that for residents doing fellowship or medical students going into radiology. Faculty got to fill out evaluations of the residents after rotations. Some program directors have to do budgeting and operating expenses for their program. And, the big one, recruitment, we probably don't need to go into great detail at this moment on the time commitment it takes to recruit for our programs. But when we're doing that, we aren't in the reading rooms. And I think if you talk to a lot of especially new hire faculty who are going into, academic jobs, and you say, why are you going to do academics? And, a lot of them will say, I enjoy that clinical teaching at elbow. I like to teach residents how to do radiology. I like the reading room. I like reading cases. But there are these other things that we need to do. And, again, back to some solutions for our math problem of too many studies, not enough people. We're not going to delay care. That's not appetizing for us or certainly for our patients. So are there ways we can increase our time available to read studies? All right. So one option might be to try to decrease some of the time it takes to create didactic conferences. This is a little bit of a different angle on the high volume difficulties, and in doing that, maybe make more use than we have of some of the high quality available asynchronous learning material. For some academic radiologists, making conferences is hard. It takes them a lot of time and they don't enjoy it. For some, they love it. And, there's probably a balance here. Of course, the ACGME requires us to provide, a robust core didactic curriculum. We got to provide specialty clinical content, non-interpretive skills, physics, and we've got to repeat it at least every 2 years, and some of the conferences have to be interactive, all right? So with that, all of our programs have strengths and weaknesses in our didactic curriculum, our conference curriculum. And those change as faculty come and go. You might have this great person now, but now they've moved on or retired. But, what do you do when there really isn't enough time in the day to teach at elbow, read cases and teach in the reading rooms and create conference material, especially if you're in sections that are short staffed? And we're going to talk a little bit about that. And this is where kind of maybe using some of this asynchronous learning material to decrease the work you're doing out of the reading room, maybe free up a little bit more time for the reading room. So I'm going to give an example just of what could happen. Let's say you have a short-staffed breast section. You've got multiple new hires just out of fellowship, all right? These are great people. They're super excited about working with residents and teaching. They're very close to it. But guess what? They don't have a bunch of lectures made or even interactive case conferences. And it turns out the attendings need to be deployed to a bunch of outpatient imaging centers for coverage. How are you going to deliver a conference curriculum when everyone needs to be in the reading room and doing procedures? Well, here's an option that you might want to think about. You may want to use the AAR core curriculum lecture series that is free. You can just get on the AAR educational site and use it. And you may say, all right, I'm going to assign a certain video, and these are about 35 minutes long. And with each video, our faculty will follow the video with a case conference. They can just, for instance, you assign the residents to watch the breast ultrasound video in this AAR core curriculum. It's about 35 minutes. The next day, a breast faculty comes in with just some cases on PACS. Have the residents take the cases, go down the row. They take the cases. That's not a hard conference to put together for a faculty member, especially a new faculty member. And there's a couple of great things about it. The residents want more hot seat. It's a great hot seat experience. This crowd of learners went to medical school basically online. They're used to watching video, didactic content. They like to watch things at double time, faster than you can talk. And it's also satisfies that interactive part. And again, some of you may not need any of this, but I think over time, there's some really good material out there. And especially if you're in a section that really does have too much volume to do some of this, this is actually a really good option. Dr. Sophia O'Brien at Penn gave a great lecture on asynchronous learning material and how to use it at the recent APDR RLI program director boot camp. And she kind of, these are some highlights from her talk. I thought it was really great. And there's a whole bunch out there. I think you have to be responsible as, the faculty using this to sort of look at and make sure that, you're not just saying, residents go watch this, there's your curriculum. But I think you can balance some of this with some interactive live case conferences to help you, especially when you really don't have the bandwidth due to a high volume clinical environment. I'm going to give one public service announcement on this because I think some people feel like it might be taboo to use this. You need to just supply your whole curriculum yourself. And I would say don't feel guilty if you need to use some of this asynchronous learning material. That's what it's there for. And, Pallav, Shah, and I do not feel guilty asking our residents to watch some videos that are given by some of the greatest educators and speakers in our field. I did not feel bad asking my residents to watch Priscilla Slanitz talk about mammography for 35 minutes. And then one of our new breast faculty did a case conference to follow. It was hot seat. It was fantastic. Residents loved it. We got great feedback. So just, again, a different take on the high volume environment where we're trying to free some faculty time up so that they can handle some of the volume. And with that, I'm going to shift over and hand over to my colleague, Pallav.
Thanks, Carol. Can you hear me?
Yeah, I hear you perfectly.
Okay, great. I am trying to figure out my screen that's active because it kind of jumped when I tried to share before. Don't think that's the right one. Give me 1 second. Otherwise, I have to share your screen if possible. Let's see.
Yeah, let me know if you want me to share.
Yeah, I'm just going to try it one more time on
Yeah,
sharing.
no problem.
I think it overlapped because
Always
I tried
my
to do it
problem.
while you were on. Can you hear me still?
Yeah, yeah.
Okay, give me one more attempt at it,
No worries, no worries.
and I think this is it. All right, you should be able to see it now.
Yes, we see it, Paul.
All right, perfect. So I'm starting off right where Carol left off. For those of you who don't know me, I'm Pallav Shah. I'm a program director and a neuroradiologist, and we recently started a program about 3 years ago at St. Luke's Health Network. We're a large institution, about 16 hospitals, probably do about 1.3 million radiology studies, have a large faculty, but they're hybrid. Some are coming in to teach, some are remote. So it's a mixture of faculty, and we're all busy, as Carol mentioned, and we have to figure out ways to do this, right? And so the math problem that Carol spoke of is really front and center for a lot of us, and it's a challenge because it sort of threatens the educational environment that we've always tried to preserve. One of the things Carol mentioned and we've discussed is, how do we utilize the resources that are available to us? So, as Carol mentioned, you have all these great places where you can go to and look for content, and it can help you deliver some of the didactics, right? And then you want to reinforce it with the case-based conferences. So, there are a lot of us who have gone to these sites. I would say that the adoption isn't 100%. The things that are out there take some time for you to sort out, see where it's going to fit into your current schedule. And maybe that's going to be too much of a rebuild. It may be difficult for you to even sell that to your faculty. Some may oppose it, some may feel strongly against it. But the truth is that if you look at what Carol had mentioned on a previous slide, what we really, do best is probably teach at the elbow, have cases in front of us, teach them how to teach in the procedure rooms. So right now there's a lot of resources, but they're located on a lot of platforms. And from a user perspective, it feels somewhat piecemeal, somewhat incomplete, and maybe even a little unorganized. There's probably a number of reasons why we haven't all gravitated towards this earlier. But as Carol said, we really ought to think about this in a way where we can leverage this to really help us spend more time in the reading rooms and teaching at the elbow. So we really shouldn't feel guilty. If you think about it, we actually have had asks like this before. And if you look at it from a national standpoint in terms of national resources for our residents, a number of great, outstanding academic radiologists have come together to help solve some of these problems for us. So, Carol mentioned that there were a lot of things that we are asked to do that are outside of the reading room, and things that keep piling on from ACGME and from the GME requirements. And so, for us in radiology, if you look at it, Rad Exam was a great resource, right?
Hey, Paula, are you advancing your slides?
Oh, I apologize. I think it's on a separate.
Sorry.
Sorry. Thanks for reminding me.
No, you're good. You're all good.
So looking at, national resources that are available to us, and we've all started to use in some way or fashion and in some varying degrees all of these tools. And these are kind of examples of when the academic community comes together and helps to find resources for all programs. And so the RAD exam or the APDR rotation guides, the procedural toolboxes that are created by Dan Del Pietro and Mary Scanlon at UPenn were extremely helpful to my program and I suppose to many other programs. The RLI healthcare economics milestones, that's one less thing that we have to try to worry about on our plates. And, you know, the National Imaging Informatics course is another one that really helps us teach some of those things that are challenging for some of our faculty. So when you look at this, you know, one question comes to mind, you know, should we be working as a community to create subspecialty talks that are training level specific for each of the rotations that we ask our residents to go through? So while that's a big challenge and it's not easy to put it all together, perhaps a smaller step would be trying to partner with other programs that are regional and perhaps share faculty in that platform. Perhaps there's a way with teams that we can deliver some of this didactic content amongst um, regional programs that are nearby to our program or statewide or in the same time zone. You know, and there are strengths to doing this because the residents benefit and they hear from different educators from different states and different programs. Faculty, as many of our faculty experience, you know, they need to give lectures that are outside of their program. And so it helps with faculty promotion. And frankly, it saves time. We don't have to all do the same work at every institution. So really, it's helpful. And one of the models that we've used in the past is, you know, when we've partnered for oral boards, when oral boards were around, we did citywide conferences and a number of programs came together to give these. So perhaps this is just one way of doing that. One of the other solutions, you know, that to deal with the increased volume, you simply work longer. Well, we know for wellness, as Dr. Kennedy said, we've got to be mindful of our own wellness, right? Just like we try to promote wellness for our residents, we've got to look after each other. And so, you know, many faculty are already being asked to do extra hours and extra shifts. The academic workload shouldn't be put off into these off hours and weeknights for us to put together our research or our talks. You know, we need to find proposals that increase daytime reading capacity. And perhaps, you know, we're all being challenged by our chairs or other people in administration that you've got to pull back on the academic time. I don't think that's a great solution and it's not viable in the long term. So, you know, solutions to the math problem, increased time available to read studies with the residents elbow to elbow and perhaps offload some of the didactic responsibilities or share the didactic responsibilities amongst programs. The other is to improve efficiencies amongst radiologists. And we've got a number of tools and things that, you know, some of us already utilize and some of us think about probably leveraging a little bit more. You know, AI tools, things like impression generator in our practice, that's increased efficiency almost 6 to 7% for everyone. EMR and PowerScribe summary generators to help us get that history that we need to make our reports a little more specific, and it's helpful to not only faculty but also residents. We are constantly doing PACS and EPICS and PowerScribe upgrades to help with these efficiencies, and we have things like Sector Chat, for example, that allow us to share you know, cases easily with a quick link and also put down a comment or two. So it allows for us to even teach, even if we're not in the same room at an adjoining campus or perhaps in a separate room, but it allows for transfer of great cases. So we have lots of opportunities here. Reading room assistants, some of us have the ability to have these liaisons. I think that's helped tremendously in our program. You know, considering giving our four some more autonomy and responsibility, as Dr. Danton suggested, I think this is something we're also leveraging. You know, APs to assist with procedures. You know, there's a balance here, but there is certainly a lot that residents can learn from the APs, and these APs are often doing these procedures more frequently than some of our faculty are at times. And so I think it's important that they are also in the mix when it comes to teaching. So, when you look at this, AI tools to help with the reading room or in the workflow, um, workflow orchestration, right, is another thing that PAC systems allow us to utilize. I apologize. Some of my slides were not advancing while I was talking. So going back to some of these things, I think I've already mentioned there are solutions here and improving efficiencies, AI tools, reading room assistants, considering giving the fourth year residents a little more autonomy and utilizing the APs. In terms of efficiencies outside of the reading room, one of the things that we could really help one of the things that we could really get help on is during the recruitment season, evaluating 1,000 applications, reading through that and sifting through that. This is where AI, I think, can really help us. I think building models that help us find the best fit for our resident body, year after year, can be really helpful. So these things may allow us to really, get back to the reading room. So um, as Carol mentioned, we really can't delay care. That's not an option. We can't control how many studies come to us. What we can do is increase efficiency so that they allow us to get back to the reading room and do that elbow to elbow teaching. I think that's my last slide.
Awesome. Thanks so much, Pallav. And there's been a lot in the chat. We've been trying to answer that. And I think the group was, kind of pointed out. I like the fact that, Tabby sort of had a sort of a resident attending focus. And again, I've never managed faculty before. And I think that's a very difficult job. But Tabby does manage faculty, and I think something that Gary was saying that I thought was also really important is maybe looking at who your faculty are. There you have the teacher, you have the person who kind of mostly likes to read independently and kind of maybe harnessing everybody's strengths as long as somebody doesn't feel like, well, I'm doing all the work while that person's not. There was a question about RVU in the Q&A about is there RVU differences for people. I'll put in that our institution just started this. I'll follow up and let people know how it goes, but they have changed our RVU that if you are an academic faculty member, we do have a community practice here, that your RVU is actually worth more than the community practice, because you have an expectation to read out residents and teach and do didactics and recruitment and interview applicants and fill out evaluation forms after a residence rotation. So I don't know if Tabby and Gary have thoughts on some of that.
Yeah, I think from a reimbursement perspective, it is important to try to figure out, well, how does the department value time? And if the time spent is going to be doing teaching or reading cases, I think that if you need to be able to have more time to staff out the trainees. And so in our own neuroradiology practice, for the folks that have a little bit more flexibility to read remotely or to kind of read asynchronously, their expectation for volumes is higher than what I would expect for somebody who's in the reading room. So that's kind of how we manage it from a section perspective. Gary, I don't know if you have anything to add to that.
Similar, but it's less section based, because within a section, everyone might be teaching faculty, but for those who are not teaching faculty, their RVU benchmarks are higher than the teaching faculty. And we don't worry about kind of day-to-day changes, because people are really assessed on a 3-month period. And at that point in time, everything should average out. And the requirement is not so high that even if you are a teaching faculty and do more teaching, you're not going to be below the benchmark, but of getting your bonus or meeting your minimum requirement, teaching is not going to bring you below the benchmark, right? If you're below the benchmark, it's for other reasons. But we have a very reasonable chair and a very reasonable institution, and this is something, to advocate for at your institutions.
One of the things we've done at our institution is, just give a certain weighted RVU, or what we call as an IVU, an internal value unit, for an activity that you do, be it for a lecture that you give, or a conference that you are, workshop that you're running. A set amount of time equates to a certain value that just gets added to your day. So even when you have a resident, for example, or you have a medical student, we know that it slows you down. And at times that's quite useful to allow you to get back to a whole number that you're trying to achieve by the end of the day.
Yeah, and then Lori Dia put in there. Yeah, the RVU is discussion's important. I think that's where section heads and chairs advocate for faculty. There have been on the asynchronous platform. There have been a lot of talk on the asynchronous learning. And one of the things I will say, Selena Kelly put in there that, sometimes residents complain about that. I think you have to, the way I kind of look at it is you look at your individual sections. Like I'll say at our place, neuro doesn't use any asynchronous learning. We've got a lot of faculty members and we can deliver a content and that we think is really good. But we have other sections that had a lot of turnover. I have a lot of new faculty. So we kind of I kind of meet with each section, kind of figure out, is there something better out there than you can give? And because at the end of the day, we want to give good content. And some of that's going to be from us. Some of it is going to be from some of our colleagues that are on this roundtable. And I'm glad that sharing has become kind of the norm since the pandemic. I think it's a huge silver lining, the pandemic. I feel like we do share a lot now. But again, I just want to kind of put that out there. It's going to be different for every institution, but I think folks shouldn't feel guilty about using it because I think people feel a little sheepish sometimes. And I hope that we're dispelling some of that, if you will. Yeah, just again, looking at some of the chat, Charlotte Taylor was talking about, that there's, teaching awards and incentive scorecards. And I think there's, I think this goes with what people are saying. You can't be penalized to teach in your system. Again, and I think that's where it's so important for our section heads to advocate.
Carol, if I could, one other suggestion that I didn't get into, but if we have a minute, I recommend that divisions, you take a look at your templates, and we know that templates can make people more efficient, but they also can make people less efficient if they're poorly developed. And then what I like to do, and I work in the ER, it's a very high volume environment. We typically start off our residents on more of a detailed template that's very itemized because they're early in their training and they want to, you want to make sure that they have an outline to hit everything. But as they get better and they get to a more progressive level of responsibility, I'll switch them to a more, what I consider like an attending level template. It's briefer, fewer headings, fewer details. And what you'll find, I think, is your faculty will have to spend less time editing reports, right? Because the more things you have in there, the greater the opportunities are for a resident not to like take out a negative. They put in, they forget to delete no brain bleed, right? And then they're describing a huge brain bleed. So the more simple that you can get them as they get to a higher level, that can really save your faculty some time. When a resident sends me a neuroradiologist temporal bones template, For my, trauma, the temporal bones, I'm like, oh my God, what am I gonna, it takes me an extra 10 minutes deleting all this stuff that I don't remember, right? So maybe that'll be helpful.
Yeah, that's a really interesting idea. I'll say one thing that I mean, both Tabby and Gary and Paul, all three of you kind of talked about this, and yours is sort of the senior level resident, the fellow. Those people now can make us more efficient. And I think that, how you help them also be more efficient helps you. This may be very controversial. Don't throw tomatoes at me. But for instance, our fourth year residents, we gave Rad AI impression generator to them. One of it is I'm trying to teach them how to use it effectively and that kind of thing. But it helps their efficiency. There are different ways, that you can help your seniors in your reading rooms. They also help our efficiency. And there are different ways to do that. Templates. I hadn't thought about that, Gary, to have different ones, but I think that's a really interesting idea. Yeah, and then Hillary Gardner put in a really interesting in the chat. Look at that. I think that's also a very interesting idea. I mean, I think, as the time is wrapping up, I think one of the things I like about what people are putting in the chat and what everybody is saying, I think we have to be creative it's not going to be business as usual where we just sat right down next to the resident and we went over all their cases and talked about stuff and then we went back. It's a new day. The volumes are really, really high and the complexity of case, I think, is also really high everywhere. And, these are all of these strategies, at least has given me some great ideas to look at in our reading rooms and outside of our reading rooms, and maybe helping our faculty, deliver the in-person teaching maybe a little bit better, but also maybe some of the other parts of the training program in addition. So I don't know, does anyone else have anything to add as we've got 2 minutes to go?
I think I might just kind of close it up by saying that, as somebody who manages other faculty, I'd say that the trainees really respond to our energy. And so if we bring positive energy to the day, to our privilege of actually teaching them and then taking care of patients, I think if we are kind of balanced in how we do it, our learners and everybody around us are going to respond to that energy. So I'd say, that's like one thing that I really try to emphasize, not like, toxic positivity, but like think about that as we are, kind of approaching our positions and kind of using that as an opportunity.
Yeah, actually, Tabby, thank you for adding that because it kind of also dovetails a little about what Gary was saying. Instead of saying, "Oh, just send me your report," saying, "You're doing so well that I think you're ready to kind of do it and then send me because you are doing so well, and I'll give you feedback," is a very different delivery and received very differently. And I think that those are, I mean, I agree 100%. The positive energy in the reading room and making sure they understand when we are teaching and giving feedback is really important, and they will feed off of positive energy. So I completely agree. So with that, again, thank you all so much for attending. We really appreciate it. This is obviously a really interesting topic that could be talked about for a while. Hope to see some of you all in Atlanta soon at AAR. And again, thanks for giving up an hour today out of your reading room. We're not reading studies at this moment, so we'll leave and get back. But thanks so much, everybody.
Thank you.